Well, friends, welcome to today's session. And today, myself and Dr. Girija Shivakumar will explain to you some points on CBME anatomy, and we will tell you about the groups. And over to you, Dr. Girija.
Yeah, thank you, sir. Good evening, participants. After the grand inauguration of our CBME anatomy workshop, is our second session. We are all meeting on this digital platform. I'm happy to welcome you all to this program on CBME anatomy. And firstly, let me express my happiness along with Dr. Sanjay Bedi for this huge number of registrations for this workshop. And this itself, it shows that how much the anatomists, we people are all involved very much into this CBME curriculum, to know about this CBME curriculum. Let us start with the CBME anatomy, about the medical education, and what are all the basic cracks involved in this. We all keep talking about the CBME and all. Wherever you turn and wherever you see and whoever you meet, in 5-minute discussion or the conversation, at least minimum of 10 times, we would be uttering the word CBME. And this word remains little fancy in the current medical education in India. Many of us are familiar with that. Some of us are not familiar with that. Means we would have heard about the word, but we are not familiar with that. And handful of people are not at all aware of what is that CBME, what it is doing in medical education, all those things and all. And here in this platform and in this workshop, we all are together as a mixture of people. What I said just now, like the known people, the unknown people, the new people, all those. And here we all gathered today and in this workshop of the next 4 months to how well understand this medical CBME and how to go about it, and how to implement, and what are all the tricks and tips involved in it. To start with, the medical education in India. The medical education in India, it started in the early days of British rule with the aim of delivering the quality health care to the society. With the evolution of changes in the curriculum and in the political scenario, the entire medical education in India, it underwent a number of changes then and there. And in the middle of 1990s, like in 95, 96, 97 and all, there were huge discussion went on regarding changes to be implemented in the medical education. And in 1997, some changes were made with the curriculum so that the early days, 1.5 years curriculum has been made into 1 year, and some other changes have been made into the subject-wise curriculum. Everything have taken place. Since then, from 1997, there were no changes occurred in the medical curriculum, and the same stuff was being followed till 2019. Even though steps have been taken by a number of medical education revolutionists, researchers, there were no much big difference or a big change occurred in medical education. In 2004 or from 2004, many medical educationists, they analyze, they research, and and took a number of feedbacks, quite a number of feedbacks, and they done a number of work on this medical education reformation, and finally the outcome of their research work is our Vision 2015, MCI Vision 2015. Though the document says Vision 2015, it took 4 long years to get implemented so that it became Vision 2019. And that curriculum is the one, what we call it as the CBME, Competency Based Medical Education Curriculum in India. Now, why there is a need for such a CBME based curriculum when the good old traditional methods were found to be very effective in those days, or in the previous or in the years of the medical education? Were not the exterior doctors are good in their quality? Were not the exterior doctors were skilled enough to deliver the healthcare to the society? Yes, of course, certainly they were all the best doctors delivering the healthcare to the society. Then what made this CBME curriculum to be implemented? With the increase in the number of medical institutions, with the changes in the students entering the medical institution, certainly there arise a need for CBME curriculum to meet the societal needs and to match the global standards. There was a situation arose mandatorily to make a change with the medical curriculum in India, and that derived this document, the MCI document, the Vision 2019. The CBME curriculum involves the vision, objectives, principles, introduction of modules, how to go about a way forward. What are the objectives of the CBME? The main objective of this document is to produce a competent Indian medical graduate on par with global standards and quality. They should meet all the requisites to be a quality healthcare provider of first contact in the society. What are the principles involved in CBME? There are some few principles which says there is a slight change needed from the traditional method into this CBME method. One is the teacher-centered should be changed into a learner-centered. The other one is the subject-based into an outcome-based. The other one is exam-based to a skills-based. Means the marks-based into a skills-based. Earlier, the student's achievement was marked by the scores earned by the student. And now in the CBME, it is the skills earned by the student rather than the marks scored by the student. With this vision and the objectives, here the MCI document, it classifies under 5 major competencies for a healthcare provider. The outcome of the MCI document. It should be the best clinician, the best leader, the best communicator, the lifelong learner, and he should be a professional and ethical. To achieve all these things, the same content or the same syllabus what we were following in the traditional curriculum, the same has been reframed. There is no much big difference between the traditional syllabus or the curriculum on the CBME curriculum, but here and there are slight modifications and the reframes have been done to achieve the outcome based curriculum. There are some modules introduced by MCI. These modules include competencies, under which there are also some more sub-competencies. There is a need for early clinical exposure, assessment, alignment and integration. The module 5 is the skills training and 6 is the electives. And this whole thing is applied, or it is applicable to all the subjects which are included in medical curriculum. And now here we are to talk about the CBME anatomy exclusively. So now we are going to concentrate only on the anatomy part, how we are going to make the modules and how we are going to train the students. As far as the CBME is concerned, we the teachers are no more the teachers, but we call us ourselves, we have to call us ourselves only as a facilitator. No more a stage teaching. It's going to be only a facilitating teaching where the students will be learning by themselves, and we all will act as a facilitator to facilitate their learning experience. With this basics, we now get into the anatomy, where in the MCI booklet, it is given with the number of competencies and the outcomes. As far as the human anatomy is concerned, we have 82 topics included under the competencies. Under these 82 topics, there are 409 outcomes. So what is a topic and what is an outcome? A topic is the main competency, what has to be taught to the students. So when you see to the topics 82, under each topic, for example, it will be the axilla and cubit or cubital fossa. So this is a topic. Under that topic, there will be some competencies. In axilla, it will be the axillary artery or the brachial plexus or boundaries of axilla or the structures present in the axilla. So under that particular topic, we will have a number of competencies. And those competencies, what are all the outcomes of those competencies is the number given in the anatomy. This is how we are going to go about that. All these details are being given in the module 1. So each competency, we can divide them into sub-competencies. That is, we can divide them into the subdivisions. Now the competency is being divided into 3. As a core competency, sub-competency and non-core competency. Many of us are working under the government universities, which classify the traditional method itself. We have the division, means like must know, nice to know, desirable to know. We have such a classification of the content or the syllabus for every subject. The same thing is being mentioned in CBME booklet with a different terminology. That's all. When we compare or when we look into the other foreign universities where they have a structured curriculum with the same what our CBME is talking, they also have a same plan of competency, core competency, sub-competency and all. The same thing is being implemented over here with the tailor-made content in the CBME suitable for Indian scenario. So based on that, the core competency is the one which will include the must-know content of anatomy. The sub-competency will be the subdivisions of the core competency. For example, when we take the core competency, axilla. So the subcompetency will be the contents of axilla or the axillary artery or the brachial plexus. These will be the subcompetencies. And non-core competencies, if you see, in the brachial plexus, what are all the minute levels of each root and the trunk, which can be included as, if the students, if they know, it will be well and good. But it is not mandatory for the students to know about that. Those will be the non-core competency. So the non-core competency will be concentrated by the highly studious one who will have the thirst to learn more about the subject in depth. Whereas the core competency and sub-competencies will be a mandatory one for all the students to know. So that's how the competencies have been classified. In the booklet, it will be given with the core competencies or the main competencies in anatomy. And it's our duty to subdivide them into some sub-competencies. That is the module 1. So all the study materials are being shared by Dr. Sanjay Bedi in our Google Classroom. And in the coming sessions and all, I request all the participants to go through those contents or the study materials and to get familiarized with the booklets. Even if not the other booklets, we all have to go through with the volume 1, the MCI booklet, which clearly gives all the competencies and the outcomes. And in that booklet, it is beautifully given with how to integrate, what subject to integrate, when to integrate, all those things and all. And at the end of this session, we will be discussing more about that booklet. So coming to the second module, early clinical exposure. Here we all, most of us, stuck how to go with the early clinical exposure. If you read the booklet carefully, the early clinical exposure can be done. The booklet given us some options. Nowhere it is mentioned that it is mandatory. They have given options like simulation, videos, direct patient, or you can have a model. So these are all the options given when you want to do the early clinical exposure. For example, to do an early clinical exposure, first we have to make a list of topics. What all you want to give the students an early clinical exposure. Of course, not for all the anatomical topics we can give an ECE. There are certain topics in every region. Take if you into the upper limb, you can have some early clinical exposures for the clinical conditions like the claw hand, Saturday night palsy, or APTM, or wrist drop. All these things we can have early clinical exposure. Any shoulder, means any shoulder injury. So now our duty is to make a list of topics in region wise, what all we can do early clinical exposure. Second thing is, what method you are going to adopt for ECE. Whether you are going to give them a video based one or a direct patient exposure, or you are going to do a simulation method. So that we have to choose. Then we have to frame a case. First, we have to give a question and a small assessment method. And here I have given one example. What is given in the booklet, 20.5 in anatomy. Under anatomy competency, there is 20.5 where it is given, explain the anatomical basis of varicose veins and deep vein thrombosis. And this can be integrated with the general surgery department. And the assessment type, it could be a short answer question, case-based question, or in a practical we can do with the OSP. So this is the scenario. How we are going to teach this? First, every institution, they have some type of patients, means like they'll have a repeated patients of one type. For example, in our hospital, there are a lot more patients of hysterectomy, and we do get very frequently the inguinal hernia patients. So where we have more number of same type of cases, those cases we can choose as direct patient method. Where we cannot show them the direct patient method, there we can use the videos. And where we cannot have the video based one, there we can give them a simulation method. So for example, the wrist drop, claw hand, these are all the small cases which we can teach them with the simulation method. So the module 2, it says about early clinical exposure, and again it is up to us to decide on what are all the cases we can do for ECE, and according to the list, what are all the classes we are doing, in that part we can do with the ECE. For example, when we are going with the module of upper limb, along with the module of upper limb, you can choose the cases, and when you are doing with the ulnar nerve or the median nerve or the radial nerve, accordingly you can take the ECE also along with that side by side. So this will give them an alignment with their teaching learning methods or the topics what they are going and the ECE. This is module 2. Coming on to the module 3. The module 3 completely talks about the assessment. There are two types of assessment, formative and summative. The formative will include all type of assessments, means it will include the theory, the practicals, the viva, record books, log books, AdCom, everything will be included in the formative. And summative is the one which they will be appearing for the university exam. The combination of all these assessments in the formative method will be included, or it will fulfill, or it has to fulfill the requirements for the internal assessment. So if the university has fixed some 50 marks for the internal assessment, out of that 50 mark, how much mark you want to give for the internal assessment, and that marks how you have derived. For example, 3 theory exams, formative assessments, or 5 theory formative assessments, theoretical assessments. So the average of all the 5. And again, coming on to the practical, coming on to the OSP, viva. So we have to combine and derive an average, and clubbing all these things and deriving a mark for 50 will be the internal assessment for the students. So we have to make frame a definitive pattern of assessment for every formative system, and under that formative system we have to give an assessment part on the return, as well as on practicals, as well as on viva. So this exact pattern of the assessment method is being given in the module 3, and in the summative assessment, this is how it's given in the summative assessment, that is the university examination. Whether it is a government university or a deemed university, this is the pattern. Uniformly it should be followed everywhere across the country. That is the main aim of MCI, to bring in the uniform pattern of teaching and the uniform pattern of assessment. So as far as the anatomy is concerned, they have theory papers, 2 papers, each 100 marks. It will be 200 marks. The practicals and orals will include 100 marks. So out of this 300, the marks will be into the theory and practical, in which minimum they have to get 50% separately in theory and viva. So the internal assessment, what we said earlier, the combination of the different assessments under the formative assessment all clubbed together, the student should gain 50% marks in theory and in practical, and both should not be less than 40% in each one to become eligible for the university examination. We need to make a note of it that internal assessment marks are not included or will not be included into the university examination marks. The internal assessment is only to gain an eligibility by the student to appear for the university exam, and in the university mark sheet this IA will not be shown or will not be included into the university mark sheet. Now coming on to the number of tests to be given in each professional year. So as far as our anatomy is concerned, in the first phase, every type of teaching learning methodology or every type of competency, we need to have an assessment and it has to be recorded. And we do have the ADCOM also as a component or a part of their assessment. So minimum, the university or the MCI says there must be minimum 3 assessments in a year. And out of the 3, the third one should be a pre-university assessment. And this examinations can be conducted in the form of written or OSPE or OMP, that is the 1-minute preceptor, or you can observe them as a direct procedural skills. First, coming on to the theory. The theoretical part, the writing exam, the written part, it should contain or it will have long answer question, short answers, short notes on ADCOM, reasoning, and multiple choice. Out of all these questions, the ADCOM will be included for their formative assessment, and that will not form any component in their summative assessment. For example, I hope you all remember our school exams up to 8th standard. When we were doing the schooling, I suppose we had a question or the class test on sports. Even though the sports questions will not be asked in our final exam, but we used to write some questions or a test on sports, which we had it as a class test. So that will be included for the internal assessment in schooling, but that will not be a component in the final exam. The same way, the ADCOM is a component or a part of formative assessment, which should form one of the components of the internal assessment, and that it will not be a component in a summative assessment. Excepting the ADCOM, all the other questions will be there in the university paper, that is in the summative assessment. The long answer questions. When we see to the booklet gives a number of examples in all the phases, the preclinical, paraclinical, and clinical phases. For in the every volume, in all the 3 volumes, after the entire content of the booklet has also given some sample questions in the booklet. So for a long answer question, what the booklet says, it should be a problem based one where the students should apply their knowledge and integrate the knowledge with the clinical case, and they should be able to derive the answer from the case given. For example, this is the one question sample given in the booklet. A 6-day-old term neonate has presented with jaundice noted at 3 days of age. He is born out of normal delivery at home. On examination, he looks pale, has a liver 5 centimeter and spleen 2 centimeter, and other systemic examinations are normal. And the question, it goes on like this. When you see carefully with the booklet, in the volume 1 especially, I suppose there are no question samples given based on anatomy. Most of the cases are given based on physiology or on biochemistry. And here is our challenge to develop questions for long answers in this pattern. Now, we go to a sample of anatomy question. A 25-year-old male was admitted into general medicine OPD, reporting with pain below the tongue. On physical examination, a small mass was identified. Radiological examination revealed that there is a small calculus. Now, this is the case scenario, and from there we are deriving the question. Identify the structure involved in it. Give it structure and relation, anatomical structures and relation, its nerve supply and blood supply, applied anatomy. Actually, give its structure. In this question, it should mean the gland. So now this is the sample question in anatomy, how it should be framed for a long answer. So the student should be able to identify this case, and he should be able to describe the submandibular gland and the submandibular duct, its nerve supply and blood supply, and applied anatomy. So the long answer question, it should be a case-based one, and it should have the splitter. If the essay question carries 10 marks, then each subdivision or each question derived from this case scenario, it should carry the split up marks. The 10 marks, it has to be split among these things. This is a long answer question. When we come to the short answer questions, the short answer questions can be a definition, or it can be a muscle attachment, or it can be a direct question. The short notes, mostly it has to be in an applied aspect, like McBurney's point or appendicitis or types of hernia. So these are all the applied short note questions. And formative assessment, the ADCOM. In the ADCOM module, those who have attended the ADCOM training at the regional centers, you will be having, or those people will be having the ADCOM module with them. So in the first phase, what are all the attitude and the behavioral skills the students should learn and earn is given in the booklet. So we have to take out those modules, the ADCOM modules applicable to anatomy exclusively. We have to frame a type of teaching learning methodology, and from that we have to assess the students in a formative assessment. So we can give them some small questions in that. How would you behave in a dissection hall? How would you behave yourself in a dissection table? How would you handle a specimen? What you will do, how will you react when you see the specimen affected with a fungal spreading? Like that, we can give them some small questions in the ADCOM. We can assess them with their behavioral skills. And reasoning questions, again, we have to give them a case scenario. We have to reason out this case, and this shows the symptoms, reason it. And of course, MCQ, we all are very well exposed and experienced in making the MCQs. So that's about the module 3 assessment. Module 4 is the alignment and integration. There are two types of integration and alignment. We know that very well. We all are experienced with that. The vertical and horizontal. The vertical one is the one integrating our anatomy with the clinical departments, and horizontal is the one biochemistry and physiology. Our first duty is to take out the topics from the booklet, MCI booklet. What are all the topics given by the booklet, integrating with physiology and biochemistry. And now keep it separately. First, we have to make a timetable according to this integration or with the alignment. We have to align our topics in correlation with biochemistry and physiology. Vertical integration, wherever we need the clinical interpretations, there we can call in or we can collaborate with the clinical departments and we can make the vertical integration. I don't know how many colleges or hospitals are able to bring in the clinical department faculties, and how many of you people are finding it very difficult to bring in the clinical departments. Of course, bringing in the clinical people is a big task, but still we can make it successful with a small adjustment. One thing I can suggest you people for making this vertical integration, we can very well make use of these SRs, because from preclinical to clinical, now the MCI has enforced after finishing PG, 1 year of residentship is mandatory. So this we can make use of. The SR in the clinical departments, most of them will be the youngsters. They are very well flexible and they can adjust with the preclinical departments in doing this vertical integration. Rather looking for the mid-senior people or the senior most people, if we make use of these SRs, we can very nicely make possible this vertical integration. So now again we have to screen out the clinical department integrated topics and we have to keep it separate. While making the timetable, we will make in such a way that the alignment with the horizontal, it goes side by side with the topics what we are doing and the other departments are doing on the same aligned topics. And wherever we are doing the clinically relevant topics in anatomy, there we integrate the clinical departments. Say like the general surgery, orthopedics, ENT, opthal, all these departments. So the module 4, if you just read through, it is given beautifully how to make an alignment and the integration with the other departments. Coming on to the module 5, the skills training. Many a time, there is a big question in most of the anatomists' mind that what more the skills training will be there in anatomy. Other than the dissection, which is not in the assessment part, because the whole of the practicals in anatomy is only the assessment of knowledge in the form of spotters and in the form of viva and in the form of identifying the histology slides. Only the discussion part, it comes under the skills. So these skills training are to be done in such a way. The following things can be included under the skills training. There is one specification in the booklet, certification, the skills certification. So when it comes to anatomy, of course, in physiology and biochemistry, if you see, there are n number of skills training in these two subjects in preclinical department. Whereas in anatomy, if you see, we can make use of these things under skills training for the students. One is drawing the histology diagram, how best you can make them to draw diagrams, and drawing muscle attachments on the bones. This is one way of learning the muscle attachments on the bones by asking the students to draw the muscle instead of asking them verbally what is the origin, what is the insertion, all those things and all, and what is the action of that muscle. Better we can ask the students to draw the muscles or the muscle attachments on a bone or on a articulated skeleton. So then the student will be able to draw the muscle or color the region of the muscle attachments. And if you ask the student to do the action of that muscle, again that will be a skill. And this you can mark it as a skills training, and for this you can have an assessment part. For example, when we do the region wise the upper limb, we are doing with the competencies, the arm and the axilla. There we can teach them the muscles, the muscle attachments on the bones. And when it comes to the assessment, we can ask the student to draw the muscle or to mark the muscle attachment on the articulated skeleton. We can ask the student to do the action of that muscle, so that instead of giving them a knowledge imparting, we can give them a skills training on these things so that they will never forget about these muscle attachments. This is what is the small minute difference in the traditional method and in the CBME method. And second, next thing is demonstrating the structures in the prosected specimen. Usually what we do in the formative assessment, we conduct the practicals with the spotters and with the discussion. And this discussion, it can be done when we are doing with the dissection in the regular routine class itself, so that the students will be asked to demonstrate the structures on the prosected specimen. For example, when we are doing the axilla dissection, the students will be doing the dissection on the cadaver. And in the colleges where we do, where they don't have enough of specimen to dissect, enough of cadavers to dissect, we can ask the students to, once we can demonstrate the specimen and followed by the demonstration by the students, and again that will be another skills training. Again, that can be assessed and that can be marked in the assessment part, formative assessment, included for the formative assessment. And same thing with the surface marking of all these skills training, the muscle attachments on the articulated skeleton, demonstration on the prosected specimen, and drawing the surface marking on the subject, that is a volunteer, or on the cadaver. These three will be the major component of the skills training. So the module 5 completely focuses on skills training. Again, it gives examples on various subjects, but not on the anatomy part. And here is also our challenge to develop the skills component, in which the anatomy subject also can do a training on the skills. This is how the professional course, the CBME based curriculum, the CBME curriculum, it goes on. And we are all familiar with the foundation course, followed by the first year, and then the second year, the third year, part 1 and part 2. And at the end of the part 1, they have the electives and the skills, and the part 2, at the end of part 2, they have the internship. This is the overall CBME curriculum in India. So far we have discussed about overall view about CBME anatomy, what is going on. And in the beginning itself, I have mentioned that many of the participants, they are all well-trained people in this CBME. Most of you people have attended all the training programs mandated by MCI, that is the Revised Basic Course Workshop, and ACME, Advanced Course in Medical Education, Curriculum Implementation Support Program, CISP program, ADCOM. And few of you have not attended some of the programs, and few participants have not attended any of these programs. And now the participants will be divided into groups, which is a mixture of all these type of people, the well-trained, mid-trained and non-trained. Now, as we all do the other training programs, here also it is sharing and learning. Each group will have a moderator on rotation who has to moderate the group for every session. One person will be a record keeper to maintain all the records of activities, and each group will have a resource person in charge who will act as a facilitator. We all are here on this platform to take an authentic idea of how to implement the CBME. A number of things are given in the various booklets and the modules. How to follow in anatomy exclusively, and how to make best use of this booklet in implementing the CBME anatomy. The whole objective of this workshop is to develop a complete booklet or a suggestive booklet, including all the modules and all the things given in the MCI booklet, so as to form an anatomy component to be followed uniformly across the country, which will reach every medical college in India through these participants who have registered for this program. We all are very much thankful to Dr. Sanjay Bedi for united us all in this platform as participants and as resource person. Though we classify as a participant and resource person, this platform will be a common platform for all to share our knowledge and views and ideas and suggestions to make the best booklet on CBME anatomy. And here we are, the resource persons, the list of resource persons who are going to support every group. And it is not that we are going to say something, it's we are going to mutually share our knowledge in making the booklet outcome as the best one. And this entire team work under the captainship of Dr. Sanjay Bedi, who is Professor of Pathology, Adesh Institute of Medical Sciences. And this is the schedule, what we are going to do in the next 4 months. And the grouping will be done. Initially, we expected close to about 150 to 200 participants. But to our surprise, we have received more than 350 registrations. So we are now grouping the participants to group under each group will have close to about 15 to 20 participants with one facilitator. So tonight or by tomorrow morning, we all will be having that grouping sheet, and accordingly, you people can form a separate WhatsApp group for your closed group discussion and the activities. Here the schedule, it goes on like this. The next session will be falling on the 11th, and it goes on and on like this. And in between, you will be having assignments, and your certification is based on your submission of these assignments. And those who is going to be the moderator, and that moderator will be changing every week. Means every person should get the chance of being a moderator in the particular group. So you can decide on how you will be changing the moderator accordingly, in such a way every person in the group, they get a chance of becoming a moderator, and what are all the duties and responsibilities of a moderator. So then these assignments will be done by every group. The competencies will be allotted to every group. On that particular competency, you have to develop the sub competencies, the core competencies, teaching learning method, assessment, and the other early clinical exposure, all those things and all. And every session we will give you the activity, how to go about with the activity, what you have to do, and how to prepare that activity, everything. Each group you have to develop a Google Sheet. We are going to compile the entire activities of every group and the complete compilation of the activities of all the groups into a master Excel sheet. And that master sheet will be converted into a complete booklet, and that will be shared with all these 350 participants. So that booklet will remain as a standard uniform pattern of anatomy teaching, the CBME anatomy teaching across the country. So make sure every group you have your common sheet developed by every group, and you have to record all your activities on that particular sheet, and that has to be shared with the organizer. We will make it into a master sheet, then we will make it into a booklet. So then the assignments will be made informed to you all by every resource person at the end of their session. So I conclude my session with this. Any resource person would like to add along with this, please. I request the other resource persons also to share your views and suggestions on this. Sir Bedi sir.
I mean, excellent presentation, and you have covered almost everything, every aspect. On the chat box, I think there are some questions.
Yes, sir.
Our Dr. Asha Lata has written, our university has asked for clinical question, including in short answer, not an essay. Then
MCI has given clearly about a long answer questions. Should be a case based one.
okay. And there are a large number of compliments. Dr. Aarti says that students, your students must be very happy. You have made the things very simple. And
Thank you, sir.
And then, I mean, there are some other questions which can be taken up only when those particular topics can be taken.
Yes,
There are
sir.
questions about book. There are questions about I'll post them on the WhatsApp group, but they
Yes.
cannot be taken in. They are specific to those particular topics.
Yes, sir.
So I think we can end it here now.
Yes, sir.
If anybody wants to
Session
ask
is
a
over.
question, you can raise your hands.
Now, any resource person, if they want to add any more thing with this, please they can add also, sir. The other resource persons.
Okay. Okay, we'll ask one or two. None of the resource persons has raised their hands.
Okay, sir.
Anyone? Dr. Praveen Iyer, yes. Dr. Praveen, please unmute yourself.
Okay. Am I audible?
Yes.
Yes, sir.
Okay. Right. I think first of all, I would like to compliment. It was an excellent beginning. It's a nice introduction to our entire workshop, and I'm pretty sure that all the participants who have listened to this particular session have got a very good overview of what is in store for the next 4 months. And the way you have nicely organized the contents, I'm pretty sure that on each of these particular heads that we will be moving ahead, there'll be lots of discussion that will be generated amongst all of us. And after discussion, I'm pretty sure that things will get streamlined and we will get a very nice, document out of this particular course. So I'd like to say that and end my words here. Thank you very much.
Okay. Would anybody? I will just. There's Dr. Sanya K. Would you like to say something? Dr. Nagaraj. You have to unmute yourself. I have unmuted you. Dr. Roop Shikha.
Hello
Yes.
everyone. Thank you
Yes.
for giving me the opportunity. We have enjoyed happily joining this session. Already we have some amount of experience in this last 1 year. Unfortunately, because of Corona, children have gone home. But whatever we could do, we have done through online classes. We are still continuing to have contacts with the students, and hope to learn some more things and from different participants and all the resource persons and teachers. Thank you so much.
Dr. Devashish Bandyopadhyay.
Good evening, sir. My query was regarding the long answer. Since it has been said that MCI has made it mandatory to be a case-based long answer, the question that was framed as an example here for anatomy, if we have seen that it wasn't clear whether it is a gland or whether it is the duct we were talking about. So what happens in this case if the student is unable to identify the structure per se? Even if he has the knowledge of the gland or the duct, he will not manage to write about the answers, which I don't think is very correct way of giving a questionnaire to a first year student, where it is mostly the knowledge is cognitive based or it's informative based. So I just needed a clarification whether
Okay. I think he has gone offline.
Sir, can I respond to it, sir?
Yes, yes.
Yes. So he is Dr. Debashis.
Hmm.
Yeah. Dr. Debashish, thank you for your raising this question. Actually, I wanted this question to be raised by someone. Means this is a question of type. How the question should be framed when you are doing with the case-based questions. The question, it should be while framing the MCQs, particularly one word questions, there is some guidelines are there how to frame the question and how the case should be given, how the question should be derived from the case. So for that, insisting on that part, I made this very vague question so that you all will know, or you will come to know, or you will have a hands-on training on how to frame a question, whether it is an MCQ or a case-based one or applied one or the reasoning one, how the case should be made in such a way the question should be derived directly from the case and not to be in a vague manner. It is an ambiguous manner. Thank you for raising this question, Dr. Debashish. It should be a well-structured question, or the case should be very clear, pertaining to the gland, or the case given or the structure mentioned in the case should be the question. Exactly what you said is right. All these things we will learn a lot in the respective sessions. There are some sessions focusing exclusively on MCQ and case-based one. There we will be doing it in detail, how to frame a case, how not to frame a case, how to derive a question from the case, and how you should not derive a question from that case. Thank you, Dr. Debashish.
So I think we can continue this discussion on the WhatsApp group. I'm sure there are a large number of points to be covered, and I will also post some of them on the WhatsApp group. Thank you, Dr. Girija, and we can end it
Thank
here.
you, sir. Yes, sir.
Okay.
Thank you, sir.
Thank you.